Hello, everyone, and welcome. If you're tuning in today, you're just in time for an exclusive and enlightening event. I'm here to introduce the webinar, Reveal Hidden Physician Reimbursement Problems and Opportunities. Whether you're a seasoned healthcare professional or new to the industry, understanding the nuances of physician reimbursements is crucial. And today, we have just the expert to guide you through it. Meet Jill Arena, a renowned expert in healthcare management and the CEO of Health E Practices. With years of experience under her belt, Jill has tailored solutions that have transformed practices by enhancing efficiency and maximizing revenue. And guess what? She's here to share her insights directly with you. And here's the best part. You can engage directly with Jill during the webinar. Have any questions? Just pop them in the comments below, and we'll address as many as we can during the session. It's a fantastic opportunity to get expert advice tailored to your specific concerns. During the webinar, comment reimbursement at any time to receive a special discount on any healthcare training leader products or services. It's a deal you really don't want to miss. And while you're here, don't forget to hit the subscribe button, join our community, and stay up to date with the latest in healthcare compliance, billing and coding updates, revenue cycle management training, and so much more. Our channel is your go-to for resources for all things healthcare management. So, are you ready to uncover hidden opportunities and tackle reimbursement challenges like a pro? Let's dive in. Welcome, Jill.
Thank you, Jackie, and thank you everyone for being here today. We are, as Jackie said, going to talk about revenue opportunities, and we're going to begin today by a little bit of background and understanding how your practice gets paid. So I believe we are ready to advance to the first slide. And Jackie, oh, there we are. Perfect. Okay. A little bit about Health E Practices. As Jackie says, we are a national firm with a leadership team that has deep experience in medical group management, revenue cycle management. We also have quite a vertical in education and training. So I'm delighted to be here with all of you today. Health E Practices is my day job, and one of my passions is education for physicians and healthcare leaders. So we have a related not-for-profit that is called the Physician Leadership Project. And in that vein, we do quite a bit of training with physicians. So the material we have today is for both physician audience and administrators and managers as well. And as Jackie said, I'll be happy to take questions at the end. So I want to start with setting the table a bit and to talk about who pays for healthcare in the United States. So these are long data sets. I believe it's 1960 to 2022 encompassed in this pie graph. But this becomes important as we start talking about the reimbursement system as a whole, is to remember these slices of pie. So we have about 29% in that orange slice of pie. That is private health insurance. So think Aetna and Cigna and Blue Cross Blue Shield and those payers in your practice. The green part of the pie at the bottom is public. So that is Medicare, Medicaid, other public health insurance. And then you can see the blue sort of teal section are other out-of-pocket and third-party payers. So good to know, first of all, sort of how the payments come in. And as you look at your practices, we'll be talking a bit later and coming back to the slide about when we think about payer mix. So that's the first part for just setting the table a bit for you. You can see the total spend there is $4.5 trillion. So this is a large market, and we're going to go on to who gets the healthcare dollar. So I believe today our audience is all in the teal there on the lower left, the physician and clinical services. And so we're looking at about 20% of the pie. You can see the other large slices of pie that do a lot of lobbying. So the hospitals, pharma, devices and whatnot, insurance and public health and those kinds of things. So we're looking at a slice of the pie for physician and clinical practices that's about 20% of that $4.5 trillion pie. So that's how it breaks down in terms of where the money comes from and then where the money goes. All right. So what we have in physician practices over the last many decades is really a shrinking slice of pie. So physician and medical group reimbursement is not keeping pace with inflation. It has not for the last many years. Physicians are being limited by Medicare rates. And each year in the fall, this gets debated in Congress and the rates get set. CMS publishes the Federal Register, which we'll look at in a few slides, and that sets the Medicare reimbursement rate for the calendar year. We do have a lot of fear of Medicare audits. And so we'll talk more as we get through how we get paid into some opportunity there, I believe, with coding. Currently, we have as I said, a lot of myth and legend out there about Medicare audits, and we have providers that are coding accordingly and potentially not giving themselves full credit for the care that they have provided. So that's an opportunity we'll circle back to toward the end of the presentation. And then as we saw with the pie there, hospitals, pharma, insurers are taking a bigger bite out of the pie each year. Those groups have very strong lobby, and they also tend to be grouped in larger entities, so they have more leverage when negotiating contracts. So again, all of these factors coming together are having a depressive effect on physician income and physician revenue. So we want to think a little bit about the mechanisms by which you get your dollars, how they come in. We have, in some markets, still prepaid or capitated healthcare. By and large, that money is driven by health maintenance organizations, or HMOs. And if we were to look in the market today, in the commercial market, it varies across the country, but what we would see is something on the order of $20-ish per member per month. And so those payments come in. They're not terribly popular at this point in time. I would say in most major metro markets, we've probably got less than 5% of revenue coming in this way. It was much more popular end of the, or middle to the end of the 90s and on into the early 2000s, we saw a lot more prepaid contracts across the country. The vast majority of what we have in terms of reimbursement mechanisms is there under number 2, and that is fee for service. It's always discounted fee for service. And that's sort of a pay-as-you-go, kind of a reactive model, mostly administered by preferred provider organizations, or PPOs. And what we see on the market is, again, it varies by geography, probably on the range of $45 to $65. And I put there per widget. We'll talk about what a widget is. That would be per RVU. So we're going to break those down in a moment. The wild card that we have in the market in terms of how money is coming into physician practices is under number 3 there, and that is the value-based reimbursement. So we see that coming in a couple of different ways. The MIPS program, which is a government program that recognizes EMR usage and quality. And that's been around for a number of years in a variety of different iterations. And we see the main advice we give to clients about MIPS is that if they're well on their technology journey and they're well on their way there and measuring a lot of quality, then if they're not already participating in MIPS, it's probably a good idea. And if they're not, the cost of getting onto that program and meeting all the requirements may or may not be worth it in terms of the dollars that are paid out. So we often recommend to our clients, if they've not yet gotten onto the MIPS program, that they take a hard look at those costs before they jump in. So the second piece there under the value-based reimbursement is Medicare Advantage plans. And we're seeing quite a lot of reimbursement come to groups who are managing their Medicare Advantage panels, where they are focused on their risk adjustment factors and where they have their physicians well-trained for the HCC coding. And that is, again, a little bit of a wild card for groups. In general, we can observe The larger groups that have a bit more sophistication tend to do better with that value-based reimbursement and taking a larger percentage of their revenue in a quality payment as opposed to the discounted fee for service. So that's what we're seeing in the market in terms of how dollars come in to medical practices. And now we'll start talking about how revenue happens. So I talked about a widget a moment ago. That is a relative value unit there in the first box. The relative value units, and we'll take a look at this in the source document in a moment, has three components to it. So there is a work RVU, which many of you may be familiar with. Those are typically used in physician compensation agreements. We also have a medical malpractice RVU and a practice overhead or practice expense component to each RVU. The sum total of those three is the RVU value for any particular CPT code, and we multiply that times a conversion factor. So if your clinic, when they're sending out bills, they will send out your claim, and so we'll use sort of a retail conversion factor. And to put some numbers to this, we typically recommend that be around 300% of Medicare, or in today's dollars, somewhere in between $90 and $100. And that's a reasonably decent conversion factor to use as retail when you send your claims out. So that would be your charge master, and that would be how your claims leave the clinic. That comes back as a payment from the insurer and the patient, along with a contractual adjustment. And so the contractual adjustment is the difference between what you've charged on your charge master, or sort of your retail price, and what you've agreed to accept from the insurance plan as your contracted rate. So there's always a difference between the two. And again, to put it to numbers, if your conversion factor on your charge master is, say, $90, and you've agreed with Blue Cross or Aetna that you're going to accept $60 per RVU from them, then your contractual adjustment would be the $30. So that is how the revenue happens. We'll go a little bit deeper on this one so you can see the math. So looking at some numbers from this year, if someone in your clinic is taking care of a patient and they have billed 99213 for an established patient office visit in 2025, CMS has said that that is carrying 2.75 relative value units. That's the total. Medicare is reimbursing $32.35 per RVU. So your traditional Medicare allowable for that 99213 visit is going to be about $88.96. You can read down there, we've dropped in the open card Medicaid rate from Oregon, where I'm sitting in Portland. And so that same 99213 visit for a Medicaid patient would reimburse about $78.36. And then if we were to see someone with a Cigna or an Aetna, or in my case, a Blue Cross card, that same 99213 visit would be approximately $60. That varies quite a bit based on group size and their sophistication with contract negotiation. But at the end of the day, the medical group would be paid about $165 for that same visit. So as I said, when we were looking at the pie charts earlier, we want to talk a little bit about your payer mix as a group. And this is where one of the opportunities you have to look at. As you look at these numbers, you can certainly see how the math works there with how much that same visit gets reimbursed based on different payers. I love to say all patients are created equal, all payers are not. So you can see the difference in the numbers in the right-hand column there on the bottom. And what we encourage our clients to do is make certain that they have managed their payer mix in a very thoughtful and intentional way. The other bit of math to add here for all of you, and if you don't know this number for your group, it's a good one to calculate, and that is your total cost per RVU, and that is fairly easy to calculate. Basically means taking your total costs over a period of time, leaving out any compensation to your physicians and your clinicians. So this is just the cost to operate the clinic before you pay the clinicians, and divide that by your total number of RVUs generated over that same time period. That is a very strategic number to know for your group as you go into negotiating insurance contracts. You certainly don't want to accept any contracts that pay you less than your cost. But for most groups, as we do this math, that number winds up somewhere in the $40 range per RVU is the cost. So that's your staff cost. It's table paper and tongue depressors and keeping the lights on and paying for IT services and all of that. So when we think about the cost per RVU being somewhere around $40, you can look at the reimbursements there in the center column, and you begin to understand that for most practices, Medicare and Medicaid are a loss. So each time you see a Medicare or a Medicaid beneficiary, chances are good your clinic is losing money if you're in a private practice. And so the payer mix conversation comes up again in that in order to be financially viable, any group needs to manage its patient mix in terms of which payer they come from so that you have enough commercially insured patients that it covers your cost and then allows you to pay your clinicians and your physicians some money to take home. So that is a main point that I always love to talk through with groups, is why we care about your payer mix and why we're interested in making certain that you have enough of the right insurance coming through the front door. So the practices we work with are all very committed to taking care of Medicare beneficiaries and Medicaid beneficiaries. And I love that. And with my business person hat on, I always smile and say, and you need enough commercial patients to leave the lights on, keep the lights on, and make your payroll. So this one is an important bit for, I believe, administrators, managers, and physician owners to understand the underpinnings of the math. So I'm guessing most everybody on this call is familiar, so I'll do these next two slides quickly. The CPT codes, the CMS RBRVS system, the resource-based relative value system, lists all of the CPT codes, which are 5-digit codes for every service that can be done to the human body. CMS has assigned a relative value to each of those codes, and I use the word widget in describing a relative value unit, so for ease of presentation. And for an example, we can see office visits generally, somewhere between 2 and 4 widgets, if you will. And brain surgery, last I looked it up, neurosurgery runs about 64 widgets. So that will help you if you're thinking about a difference in compensation level between, say, a primary care doctor who might see 20 office visits in a day versus a neurosurgeon who might perform 2 neurosurgeries in a day. You can do the math and understand where the reimbursement levels are and where the compensation levels are for those groups and everything in between. So let's see, I think I may have hit that button. Nope. So this is the RBRVS schedules. I said we were going to go to the source document. This is a large spreadsheet. I'm an individual who loves spreadsheets, but we won't stay here for very long. This is downloadable from the CMS website. This is the 2025 National Physician Fee Schedule for the relative value unit. So as I said, you can see there the 99213 is highlighted. You can see the addition of all of the various different RVU components there, the work, the non-facility practice expense, and then the malpractice, all adding up to the non-facility total, which again for 2025 is 2.75 RVUs. This particular clinic is using our fee schedule builder, and they use a $90 conversion factor. And so that gets them a charge for their 99213s of about $248 per visit. So, and this is a tool that we have that we provide for free. So if this is something you'd like in terms of your fee schedule builder, if you aren't in the habit of updating your fee schedules annually, I highly recommend that you do. This is a tool we share for free. So if you'd like a copy, we've got all my contact information at the end. You can shoot me a message and we'll get you a copy of this that you can use at your clinic. All right. Now, this is a little slide to just explain how the math works. I think that was probably fairly clear to everyone, but your practice management system or your billing system takes that non-facility total each time one of your physicians clicks on a 99213, it issues a claim based on that conversion factor that you have. So that's how the claims go out. And I'm sure everybody's also familiar with ICD-10 coding. So International Classification of Diseases, version 10. And it's 7 characters, alphanumeric. The switch from ICD-9 several years ago added a number of characters and also gave us some extra placeholders for more specificity. So that is an important part of coding. We'll go on to the next. So as a quick overview, again, I'm assuming most people on the call are pretty familiar with this. Your doctor or clinician sees the patient. They put a CPT and an ICD-10 code on the claim. That is transmitted electronically to the insurance companies on a Form 837. The insurance company, hopefully, pays some of the total of that claim, and they return a Form 835 to your office inside of the claims system. That should all happen electronically. And we're seeing clean claims adjudicate anywhere from 5 to 10 days, depending on the market and the codes. And so your office then processes that 835, figures out what the insurance company paid, and goes back and sends a bill out to your patients for their portion. So, and that fourth step there is where the contractual adjustment is taken. And then the patient is issued a statement if he or she has a balance that they owe. So that is the whole of the sequence. So here are some of the coding and billing games that we get into. The insurers create rules. Everyone at your office is smart and you figure out those rules. So now we have a new set to play by. And then the insurers create some more new rules. And then again, everybody figures those out and you can see how this builds up. And we get to this place where you have probably in any major metro market, 10 to 12 major insurance payers on the commercial side that you're attempting to keep up with, all of whom have their own individual medical policies. They have exceptions to, rules that CMS has generated. Some of them follow all the CMS rules, some of them don't. So there's quite a bit of confusion and administrative burden that goes into simply getting claims paid. This seems like it should be an easy thing. You can see that when a claim arrives at the front door of an insurance company, it needs to navigate approximately 52,000 claim edits, which are all the rules that the insurance company will write in order for a claim to go through and get paid. So this is the environment that we're all living in and trying to be successful in, and it requires some patience and sophistication and some tenacity as well. So I would not want to open the front door and see that kind of maze in front. So here's the result of all of this insanity as we've been setting the table for today. And that is physician reimbursement is an expensive and complicated proposition. And this gentleman here looks like he needs some Tylenol or some Excedrin or something. But that is the sort of current state of the state of our reimbursement system today. So what we see are contract rates are not stepping up the way we would like to see them. They're not keeping up with inflation unless groups are really on top of that. That has a depressive effect on salary levels for physicians. Also has a very depressive effect on margins in the average practice. So depending on your subspecialty, especially in primary care, the profit margins can be very thin. And that's challenging at best, especially when we have a lot of very hardworking people putting in a lot of hours in a very altruistic fashion, and the reimbursement is continuing to be flat or declining. That leaves capital funds or R&D, research and development funds, also very minimal in the average practice. So attempting to grow or invest in new things is typically very challenging for groups. So we see groups always looking to increase revenue and decrease costs, both of which are smart financial moves. So that's where we focus a lot of our consulting effort on around those two things. But that's where we're at in terms of the current state. So when we stop and think about that, one of the questions that comes up is, what is a physician to do? What would be logical action steps, given that we've got reimbursement that's flat or declining, and it seems we have to be working harder and harder. So some of the things that we see, things that happen accidentally, one would be the subpar billing that I talked about, and we'll come back to that in a moment. The undercoding, under documenting. We see a lot of EMR products out there that are, sort of implemented, but not really optimized for documentation and especially to support codes. So those are things on the left side there that happen kind of by happenstance or by accident. The things that we see physicians and medical groups choosing to do mindfully is see more patients. That's one way to solve some of the financial problems. We have to be very careful, especially in this era of burnout, that we don't overwork our teams and that we don't overwork the physicians in the group. And we have a lot of issues with burnout and groups just kind of feeling like they're at the end of their rope. So if you're the administrator or you're a physician owner or leader, I have three opportunities that I love to think about in terms of optimizing your revenue. And these are three different things. We'll do a little bit of deeper dive on each one. Insurance contract renegotiation. We have a slide coming up on that. Again, if you haven't looked at your insurance contracts annually, that is also an excellent best practice to get your clinic into the habit of looking at those insurance contracts, and we'll come back to that in a moment. Coding improvements as well. As I said at the top of the hour, we see a huge number of groups undercoding and therefore leaving money on the table, so we'll come back to that. Medical scribes are the third intervention that I love to see from medical groups. I'm certain everybody's familiar with a scribe. Whether you have an in-person scribe or an AI scribe or a remote scribe, doesn't really matter. I just really encourage anyone who's seeing patients and putting a note into an EMR to take a look at the various different options for scribes out there. We like to talk about everyone in the medical group working at the top of their license, and doing a lot of clerical typing is not anywhere near the top of a license for a physician or an APP. So really like to see those tasks delegated, again, to an in-person remote or an AI scribe. Any of those three. The AI scribe technology, just heard a review of the latest out there about a month ago, and that has come a long way as the AI products are improving. The accuracy of the AI scribing is also improving. So if you haven't looked at that recently, it's definitely something to revisit. The scribes, as we've said, and we've looked at this through our consulting practice, generally adding a scribe requires a physician or an APP to have an additional 2 to 3 visits each day to reach break even. So that the additional 2 or 3 visits would cover the cost of your scribe. On average, as we see physicians and clinicians getting into the use of a scribe, after about 3 months of working with the scribe or with the AI tool, the performance normalizes, and it actually takes less time. And on average, physicians are able to add 5 to 6 more patients per day once the scribe is fully functional. So that's definitely a way to do, to remove sort of a clerical thing that's, kind of a nitpicky task and not at the top of any physician's license, and add some additional revenue that well outstrips the cost of either the technology or the person. So scribes are one of my favorite interventions, as it were, on the business side for improving revenue. So we'll talk a bit about insurance contracting now as my second favorite. This is basically just going to the insurance companies and letting them know you'd like a raise. The vast majority of them will not come to you to offer a raise. They're quite happy to leave you right where you're at and pay you whatever they've been paying you. We frequently go into practices where contracts have not been renegotiated for 3, 5, 7, 9 years. And I would assert that each year your costs are going up for most everything in your office and your staff and supplies, and it's well within your right to ask your payers for an increase. So there are also a lot of consulting firms that can help you with that if that's not expertise that you have internally. Those are generally excellent investments to have someone that has the knowledge to go and both do the calculations and also do the negotiating on your behalf. So if that's not expertise you have in-house, please outsource, and please go back to your payers and ask them for an increase each year. The internal workings of the payers, we know they know which practices do and don't come and ask for increases. And once you establish yourself as a group that is sophisticated and has your stuff together and is coming back for a raise each year, it takes a few years for them to learn that you've, stepped up your game. They do know that, and they negotiate differently and with more favorable terms to the groups that they know are coming back year over year. So my strong encouragement to any group that isn't already doing that, please do. This is an example, a screenshot of a what we call a contract matrix that we generate for our clients. And again, if you'd like a copy of this, there's a screenshot here in the slides. I'm happy to send a blank template out if you send me an email. We list the plans down the side, as you can see, and then we have multiple contract terms that our group reads for, and I'll spend a minute or two on these. First of all, are you currently contracted, or are you attempting to get a new contract? We always want to know the effective date of the contract or of the rate increase once that's been negotiated. We have seen multiple examples of plans who have renegotiated a rate, granted a higher rate to the clinic, and then never loaded that into their system. So they just continue paying at the old rate. And we actually have a local client here that went back and got a 6-figure payment out of a payer because they hadn't loaded a new rate, and that went on for quite some time. So we like to check the effective dates so that your team can assure that you're being paid at the new rate once that's meant to be effective. Your conversion factor, as we discussed when we were going through the math earlier, for the commercial plans would be somewhere in that $45 to $65 range. If you're a larger group, you can certainly negotiate higher rates than that. It also depends on your metro market, but that's what we see in the market. And that rate can and should be going up for you. The next column is your RBRVS year. So the slide that we looked at with the large spreadsheet was specifically for 2025. Each year, CMS updates that. As I said, generally in November or December, they publish a new schedule for the upcoming year in the Federal Register. And the RBRVS year has a great impact on your contract negotiations because for the last probably decade or two, CMS has been attempting to give more credit and therefore shift more revenue to the practices that provide cognitive services or evaluation and management. They use the evaluation and management codes as opposed to the procedural and surgical codes. So CMS has been making an attempt to shift and have a bit more reimbursement going to primary care and office-based practices. It is, as we said in the first slides, a fixed pie. So that means they have been reducing the relative value units for a lot of the procedural and the surgical codes. So the RBRVS year is very important to note because if you are a primary care practice and you're looking at, or an office-based practice with the majority of your activity inside of those E&M codes, a newer or more recent RBRVS year will almost always be a better deal for your group financially. If you are a procedural based or a surgically based group, a newer RBRVS year may not be as good of a deal for you because of those relative values going down. So as we said, brain surgery was worth 64 widgets this year. In future years, that may go down to 60, or it may, so those are declining. And therefore, we've seen some surgical groups where they are offered a contract with a higher conversion factor, which looks good on the surface. But if the RBRVS year has moved forward enough, for instance, if they've come off of 2021 and they're moving you to 2024, that may actually represent a loss for your practice. So there is some calculation that needs to be happening in the background. And again, if you have this in-house or if you've outsourced, please make certain that whoever is doing that is doing calculations based on your practice's distribution of CPT codes, because the insurance companies know exactly what they're offering you, and they're happy to have you sign a contract that actually has them paying you less than more. So there's some fairly sophisticated calculations that need to be happening to make sure that you are getting a good deal and that what you're negotiating is actually a raise. The term and termination there, generally what we're seeing on the market is the insurance contracts are evergreen. They're typically a 1 year with a automatically renewing term. Termination is also important. If your practice reaches a point of stasis where you feel like you've got enough patients and you're not going to add any more clinicians and you just now have an opportunity to refine your payer mix, we frequently recommend our clients look at their commercial payers when they reach that point of capacity and begin to sort of strategically prune the list of groups they will hold a contract with. And so understanding your termination clause is very important. That means how do you get out of the contract if, for instance, you want to terminate it. We do have one I can identify. We'll change the names to protect the innocent, but in the Portland market, we do have one payer who is notoriously lowest on contract rates and almost always highest in terms of administrative burden of getting claims paid. They have the most frequent requests for chart notes and a lot of delay in getting their claims adjudicated and paid. And so that is typically a plan that we recommend our clients prune if they get to that point of capacity and decide that they're going to want to eliminate a plan or two and focus a little bit more on the plans that pay them well and don't create a lot of administrative burdens. So we want to be very clear in looking at all of this about what our termination clause is in the contract. And not surprisingly, those plans that I will say have a little shenanigans going on, almost always have a little shenanigans going on with their termination clauses as well. So we'll hear from them that you can only terminate a very complex language. You can only terminate 120 days prior to your renewal date, and there's a very small window, and it's made overly complex. And so I frequently encourage people when they're renegotiating contracts to look for that overly complex termination language and ask for that to be rewritten much more simply so that everybody understands. My favorite termination language is what I call a 90-day bilateral no harm, no foul, which means either party, the insurance company or your group, can give notice that you'd like to terminate the contract. You do not need to give a reason, and that you can do that with 90 days written notice. Those are my very favorite. Those are the cleanest and what I like to see. Many of the plans have those or something similar, and so you can look at those and decide, how much you want to fall on your sword to get it exactly that way. But that is definitely my favorite contracting language. But beware of any group that has funky or complex termination language, because you want to be able to run your practice as a business, and you want to be able to be in or be out of contracts without a whole lot of friction. So, next up there is, are you permitted explicitly in the contract language to bill for non-covered services? And this is important as we start to see more cost shifting over to patients. I like to see language in a contract that explicitly says that you are permitted to bill the patient for non-covered services. So there's no equivocation and no question about that. We also like to read for the level of medical malpractice coverage that they are requiring, as well as general insurance coverage. Some of the insurance contracts actually specify a dollar amount, and so you'll want to read those carefully. Just make sure that you are insured at the appropriate level so that you're not in breach of your contract. And then the very last thing I want to touch on in terms of contracts is your timely filing requirements. Those are that is the time frame in which you have to file a claim from the date of service. So if you have a 90-day timely filing clause in your contract and you see a patient on the 1st of January, you have until the end of March to bill that claim. If you bill it in April, they will not pay you. And that is something I believe is lost in a lot of medical groups, is the timely filing. And anytime our revenue cycle team goes in to look, we see, unfortunately, a lot of write-offs due to timely filing, which means for whatever reason, the paperwork didn't happen quickly enough, and the physician or the medical group did not get paid for the care that was rendered. So those are areas we love to have groups focus on, and that begins with the front desk. And that's a whole nother conversation, but just to be aware as you're looking at your contracting, the timely filing deadlines potentially can be negotiable. It never hurts to ask. And many of the national groups, Aetna, Cigna, et cetera, have 90-day timely filing. That's typically the shortest that we see. We like to see 120, 180 days. I believe Medicare gives you 365. So there's plenty of time to get claims corrected and get them filed with the correct payer. But it's not difficult. If you have the wrong payer in the system, it's not difficult to surpass a 90-day by the time you do the back and forth with the patient to try to get the correct insurance coverage. So that is a lot about contracting, but I believe most groups have a lot of opportunity there to improve their revenue by just recontracting. Getting those updated. Another thing I do want to talk about a bit, as I said at the outset, is coding, and I like to pick on the E&M, the office visit codes here. What we see frequently is a physician or a clinician going into an exam room and providing a level of service that fits the definition of a 99215. So that's what happens in the exam room. That individual steps out, either perhaps they don't have a scribe, or they're rushed, or the EMR templates are not optimized for documentation. And so the visit gets documented about to a level 214. And then the physician or APP has just finished reading an article in Medical Economics about Medicare audits and has some concern about that. And so they code a 99213, and that's what goes out on the claims. So we see this happening a lot. I like to say that, again, the scribes are a good cure for that first step down, the 215 to the 214, and training and understanding the coding system is a cure for the rest of it. But to put some dollars to this, as we go in with our coding programs to train physicians, we see groups that have these step downs going. Each step down is worth about $40 to $60 for your practice. And if you are under coding, you may also be under documenting, in which case you're in compliance, but you're just not getting credit for what you've done for your patients. But by right coding and right documenting, which does not need to be a lot of extra documentation, we see groups recapture these two steps. And in many cases, that is well into the six figures of revenue that is recaptured when we can do that with our training systems. If physicians are undercoding right now, it's a very expensive proposition, and we love to have conversations with groups to just kind of flip that notion on its head. I like to joke, I think the insurance companies have enough money. I don't believe that we need to leave any on the table for them. So this is something I would highly encourage groups to look at. And it can start with very simply just looking at your distribution of 99213s, 4s, and 5s. The vast majority of physicians should not probably code a 99212. It's very difficult to have that little going on with a patient. Most of the groups we go into, we see the coding distribution graphs peak at a 99213. And I would say, given the way the descriptions of the visits are written, and the vast majority of visits are likely a 4 instead of a 3, that is, I believe, a huge area for opportunity for groups that want to take a hard look at how they're coding. So we'll keep going here. So I've been talking through some of these points already. Here's what we're seeing. We talked about losing money unnecessarily to timely filing deadlines. If front office data collection is not up to par. We do hear frequently physicians are overwhelmed with documentation requirements, and that's where we love to dig in a little bit and optimize templates and optimize the EMR a bit. We've talked about the coding training causing under reimbursement. We do have a lot of an increase in coders who are certified, so CPCs, who are oriented to mitigate 100% of coding risk for physicians, which is a great place to get start, but they are not oriented to looking for opportunity to get the doctor or the clinician paid for what he or she did in the room. So that orientation, while not wrong, has a depressive effect again on physician incomes. And I'd love to see coders coming in that actually have healthy feedback loops with physicians they're working with and can train the physicians to code with some confidence and to code assertively, not aggressively. We don't ever want to have people over coding because that creates a different kind of risk, but to code assertively and to document well and to know that the level of care you've provided and that the note will stand up if ever there's an audit. So we love to see that when we can get all of those things in line. Looking at all of those bullet points, we just see a lot of financial strain in practices right now, and that adds then to immense burnout on the part of physicians and physician owners. So I would speak for just a moment to any physician or physician owners on the webinar today. We see you. Thank you for the care that you're providing in the community. Our communities are healthier for you, and I want to make sure that you are taking good care of yourselves and that you are healthy with how you're running your businesses. So that is my fondest wish. I think we're just about done. I wanted to leave you with some additional resources. I did put out a book a couple of years ago that is a short read. It's about 120 pages. There's a link there for the free audiobook if you like to listen to them. That's available to you. We also have a podcast that comes out weekly that is Medical Money Matters that you can find on YouTube and all the major podcast platforms. I do 3 solo casts a month that are a deeper dive on a topic. So there is one on contracting if you want a deeper dive on that. There's several on coding in there. We just dropped our 123rd episode today. So there's a fair bit there that's free for you. Once a month, typically, I have an interview with somebody far smarter than me, and we do a deep dive on a topic. So you can take a look at that menu to see if there's anything there that's informative for you. The Medical Group Management Association, mgma.com, has a large number of resources as well. I always encourage physicians to look at the AMA and your professional colleges, also your state and county medical associations, and the academies also have quite a bit of information on business, business for physicians, etc. So a lot of good resources out there. And then we have a new product coming out probably later this month that is called Physician's Edge. That is going to be a mini MBA for physicians. It's also suitable for administrators, but the audience is really for physicians. And if you shoot me an email if you're interested in learning more about that, we'll get you a discount code for having heard about it here on the webinar today. So I believe we're right at the end here. There are opportunities for everyone on this call to increase revenue, to help decrease burnout. We always need to factor in the patient care and the patient satisfaction. One thing I have learned from our medical director, Dr. Ann Hirsch, as well as many physician colleagues and friends, that physicians do need help, as we've seen with all the pressures we're having today. And by and large, they aren't great at asking for it. So if you're an administrative or a clinic manager role, you can work on becoming a trusted advisor to your physicians, and never hurts to ask, what they might need. We don't often think to ask that, but it's a great question. So, and Jackie, at this point, I am ready to take questions from the audience.
Thanks, Jill. That was such a great presentation. Okay, for everybody on the call, go ahead and type your questions into the comments section. We'll take them as they come in. And don't forget, if you put in reimbursement in your comment at any time, you'll receive an exclusive discount on any one of our products on the Healthcare Training Leader website. Okay, let's dive in.
Okay, our first question. You mentioned that payer mix plays a significant role in a practice's financial health. What are some practical steps administrators can take to optimize their payer mix?
Great question. First of all, be aware of what it is. And I would say in looking at billing systems, practice management systems, we see a fair bit of misclassification. So in some cases, understanding your payer mix starts with a little housekeeping to make sure that you've got patient insurances are feeding into the proper class of patients or category of patients, if you will. So if you're trying to figure out what percentage of your patient base is commercial versus Medicare versus Medicaid, it's important that you have all the plans feeding into the right bucket. And then in terms of strategies to help manage that, we routinely recommend to our clients that they look at their scheduling practices up front, that they create schedule templates that have a certain number of appointment slots by category. So that requires some scripting of your front desk. It also requires a little bit of education of your front desk as to the why of that. And we have at times gone in and explained to the whole team the underlying economics that we went over today so that they understand, yes, we serve Medicare patients. Yes, we serve Medicaid patients. And as we've said, all patients are created equal and all payers are not. And so we need to manage this strategically from a financial perspective. So again, we can keep the lights on and make the payroll. So we typically recommend that they do that by schedule template.
Great, thank you so much. Okay, our next question. We're a solo orthopedic practice. We're told not to approach the insurance companies for an increase because they would most likely cut our reimbursement more. What are your thoughts?
It's a great question. It's a great fear tactic. I would say approach the insurance companies. With ortho, again, you're a surgical subspecialty, so be very careful that you're doing all of the math underneath. So if they're offering you, if you're currently on, say, for instance, a 2021 RBRVS schedule in your contract and they're offering you anything newer, you'll want to take a very close look at your distribution of codes and multiply that times what they're offering you newly against the new year's RBRVS values, because your surgical your surgical RVU has been going down over the last many years. So just beware, but absolutely go and ask for an increase every single year. Please, please, please.
Great, thank you. How do you find the person to negotiate rates?
Oh, excellent question. That can be there are several consulting groups around the country that do that. You may find a local person who's a medical consultant. You may find an attorney who could do that for you if they're a healthcare attorney. The main thing I would urge everyone to do if you're selecting someone to outsource this to is make certain that they have worked with many, many medical groups, that they have a deep resume in doing contract negotiations. This isn't something you can just pick up overnight and do a good job of. Make certain that they are doing the underlying calculations on the RBRVS. And if you ask them questions about that, they ought to be able to show you their work, and it ought to be a very large, very complicated spreadsheet. And if it's not, then they don't really understand what they're doing, and I wouldn't hire them.
Great. Thank you so much.
That's a fine point, but there you go.
I like it. What if insurances say they won't negotiate rates for you?
Yeah, there are some that stonewall. And in that case, I would take a hard look at what percentage of your business that plan represents and decide if you want to keep them. But I would continue negotiating with all the others. And I will say, we see the pendulum swing. So I think we do negotiations for clients mostly on the West Coast, but we do negotiations for clients all over. And so we have some intel about which plans are saying what, what's the party line at this point in time. I've seen Aetna stonewall for a while, and then they come out of that and they're willing to negotiate again. And sometimes Cigna just refuses to negotiate. So it is dependent upon the size of your group as well. So obviously larger groups have a bit more leverage. If you own more of the market share in your metropolitan market, you have a bit more of a platform from which to negotiate. If you are a small group, though, I wouldn't hesitate to ask. The worst they can say is no, or offer you something that's a loss, in which case don't sign it. But if you are consistent with your communication and you go in with good data, again, they will figure that out about you over the years, and they will respond accordingly. So keep at it.
Great, thank you. Is there a good source for reviewing code distribution for new patients and follow-up patients?
A good source, I would run a production report from your practice management system. That should give you a distribution of your codes currently. If the question is about where you would find national averages, those are published. I believe the AMA puts those out, or CMS puts those out, so you can Google that. I would beware of using anything that is a national average. First of all, you don't want to be average, right? And secondly, the national averages are subject to all those depressive effects that we talked about. And again, my belief is where a national average for a practice would likely, again, peak at a 99213. My supposition after doing a lot of looking and thinking and calculating is that likely should be a 99214. Should be the highest distribution if you look at all of your E&M codes. So if I didn't get that question answered the way you were asking, please put another question in the chat.
Great, thank you. I'm a small private practice with an infusion suite. Does this significant medication cost factor into the practice cost RVU?
Yes, it should. And you should also negotiate those very, very carefully. We're seeing practices with infusion centers having insurance contracts that want to pay them at a loss for the medication. And I would never take a contract that asks you to subsidize a medication. The insurance companies have enough money and you do not need to subsidize the meds.
Great, thank you. And we do have just a few more questions we're going to try and squeeze in. If you don't have your current contract, how do you go about obtaining that?
One of two ways. You can request a copy from the payer, or you can send a letter that authorizes whoever your external consultant is to negotiate on your behalf. You likely need to send that on your practice letterhead, and the consultant should be able to provide you with language for that letter. And in that case, that individual can request a copy of your contract for you. And that's not unusual. When we go into clinics frequently, they can't find them all. So we generally spend the first couple of months doing that as part of the exercise. The other thing I should say, when you're renegotiating your contracts, I would expect that exercise to take 6 to sometimes 9 months. And then if you are going to do that every year, you want to start over nearly as soon as you're done, but keep at it.
Great, thank you. Regarding billing patients for non-covered services, can a non-participating provider bill a Medicaid recipient for a non-covered service?
Ooh, that's a good one. And here's where I say I'm not a lawyer, but I play one on TV. I would refer you to your state Medicaid regulations. My off-the-cuff answer on that, without knowing which state you're in, so please take this all with a grain of salt, would be if you have a Medicaid patient standing in front of you wanting a non-covered service with cash in their hand or a credit card and they are ready to pay for it, my belief is that if you have them sign a document that looks like a Medicare ABN or an advanced beneficiary notification, which you can download from CMS, and using the ABN form would be just fine in this case. That calls out for the patient, what is the service, what is the cost? They understand that it is not covered and they are willing to pay. That would be the best way to go about doing something like that. But again, I'd refer you back to your state Medicaid regulations.
Great, thank you. And then this is going to be our final question. If at the practice we decide we need to terminate our contract with a difficult payer, is there a good resource for how we need to let the patients know that we will no longer take that insurance?
It's a great question. Your state medical association may have resources for that. Any good consulting company should have resources for that as well. In general, the best pieces of advice I can give you would be to legally terminate the contract. I would give the patients as much notice as possible. I would communicate with the patients that you are terminating the contract. And I probably, this would be a question for your legal counsel. I probably wouldn't put a reason for your terminating the contract in the letter to the patients. I would just simply say, as of this date, we are no longer contracted with XYZ insurance company. We do, accept coverage from the following. And I would also put something in the letter about their out-of-network benefits if they would have any. So there's a bit of research that would go into that, but I would say communicate early and often.
That's all the time we have for today. From all of us at Healthcare Training Leader, thank you for joining us today. Please make sure to subscribe to our channel. We're constantly updating our content with vital information that helps you stay ahead in your healthcare business. Keep pushing forward, keep learning, and I hope to see you again in our future webinars.